Gil here, and I wanted to jump on and record a lecture for you for individual module 4, which is the concept of sexuality, and specifically for PowerPoint 5 talking about sexual dysfunctions. So here are your learning outcomes, same as your book. All right, so a quick overview of sexual dysfunction and what it might mean. Sexual dysfunction is any persistent disturbance in an individual's sexual response. So it can happen during any part of that sexual response cycle that we talked about under the concept of sexuality. It can make it difficult or impossible for that person and partner to have satisfying sex. It may be linked to physical, psychologic causes, or it can even be attributed to both of those physical or psychologic causes. Sexual dysfunction can last throughout a lifetime. It can be acquired due to illnesses or injuries or other types of things at some point in the person's lifetime, or it can be actually just kind of situational, depending on what situation that person is in at that time. If there's certain particular types of situations that disturb people. Sexual dysfunction can happen to adults of all ages. All genders can also be affected. There are certain sexual dysfunctions that are specific for men, certain that are ones that are specific to women. Sexual dysfunction is relatively common among adults, and it is actually more common in women than in men. It can be seen as a normal consequence of aging, but it shouldn't be viewed as normal for someone's sexuality. So I guess what I'm trying to say there is, just because someone is an older age person, they are at that point in the lifespan, we should not expect that it is normal for them to have sexual dysfunction. And just to recall your memory to what those parts of the sexual response cycle are, there are 4 of those: excitement, plateau, orgasm, and then resolution. So sexual dysfunction occurs in one or more of those 4 cycles whenever a person is having sex. Okay, so that was just a little overview of kind of what we're going to get into throughout this PowerPoint. So male sexual dysfunction has 4 specific types that are categorized in the DSM-5. There is male hypoactive sexual desire disorder, erectile dysfunction, which is the one that we see most commonly in the healthcare setting, premature ejaculation, and then delayed ejaculation. All of these have different causes and different ways that they present themselves, and all have a dramatic negative effect on the gentleman's ability to enjoy sex. So specifically, let's talk about male hypoactive sexual desire disorder first. Symptoms for this include a deficiency or an absence of sexual fantasies. These gentlemen have persistently low or either no interest in sexual activity at all. The diagnostic criteria out of that DSM-5 are the following: deficient or absent sexual thoughts or desires more than 75% of the time for greater than or equal to 6 months. A lack of desire not related to another medical or psychologic disorder. A lack of desire is very distressing for the patient. So in other words, if this lack of desire does not cause a significant stress to the patient, then it cannot be used as a diagnostic criteria to tell somebody they have this. And then the desire discrepancy between a man and his partner is not enough for diagnosis. So, for example, if the man doesn't desire to have sex, but the woman does, that discrepancy between the two is not enough of a diagnostic criteria to say that a man has this hypoactive sexual desire disorder. This is the very least common male sexual dysfunction, and many men that experience problems do not actually satisfy the diagnostic criteria because they don't have this for longer than that 6-month requirement. And then, the older that we get, sometimes the less desire that we have for sex itself. The older generation, or not generation, that's not really the right word, older persons tend to have sexual fulfillment from other, or fulfill their sexuality from other ways, other types of intimacy. So not necessarily the act of sex, but giving flowers, giving and receiving gifts, cuddling, having dinner with someone. They receive what they need from a sexuality standpoint in other ways that might not be as sexually physical as they are in the younger years. Erectile dysfunction is the next sexual dysfunction we're going to talk about in regards to men. Symptoms for erectile dysfunction include the inability of a man to attain or maintain an erection that is sufficient for sexual intercourse. It may involve total or an inconsistent ability to achieve an erection, or the ability to sustain that erection only for a very brief period of time. The penis might become semi-erect, but lack a sufficient rigidity to allow that man to have intercourse. It is also known as impotence, which is really an outdated term. We don't utilize the term impotence any longer. We call it erectile dysfunction now. And then also, you might hear people call it erectile disorder. But when you hear erectile disorder, it is usually unrelated to a physical cause. Characteristics of erectile dysfunction. It is characterized as a disorder of arousal. So that is the part of the sexual response cycle that is affected by erectile dysfunction, the arousal phase. It may or may not be associated with a loss of that person's sex drive or libido. It occurs in men of all ages, old and young. It can be chronic, intermittent or episodic. So it can be a long-term problem, a problem that just happens here and there, or very infrequently. The incidence of erectile dysfunction is pretty difficult to estimate, and the reason is because men are often embarrassed to report that they have this problem. So they might not report it to their physician. It is, there are several different views on how long erectile dysfunction must be persistent to be diagnosable. For a medical diagnosis, or from a medical standpoint, erectile dysfunction has to be present for greater than or equal to 3 months. But from a psychiatric diagnostic standpoint, that dysfunction must be present for greater than or equal to 6 months. So there's a difference there depending on who is doing that diagnosing. About 52% of men report that at least occasionally they have some erectile dysfunction difficulties. Older men tend to be affected at higher rates than younger men. And that has to do just with the normal physiological aspects of aging. The rates for chronic or complete erectile dysfunction is lower than those people who only have erectile dysfunction occasionally. So there are more people who only have occasional episodes than those who have chronic or complete episodes of erectile dysfunction. So for an erection to occur, there has to be a neurovascular event that happens. There are functional, autonomic, and somatic nerves that are involved. Smooth and striated muscles are also involved, and an adequate arterial blood flow. So what happens is that the chambers of erectile tissue in the penis are filled with blood to cause an erection. The pelvic muscle contractions actually will help increase the penile rigidity. Veins in the penis constrict, blocking blood outflow until the orgasm or removal of sexual stimulation. So there actually has to be a relaxation of the muscles to allow the blood flow to happen. And once that blood flow is trapped, it causes the penis to become erect. Those veins constrict, keeping that blood in the penis until there is a release through orgasm or sexual stimulation is stopped. There are lots of different causes for erectile dysfunction, and here are a few that are listed. Vascular problems. There can be neurologic problems, urologic problems, endocrine, respiratory, iatrogenic, lifestyle-related issues, psychologic issues, and then part of the aging process. So there's less elastic collagen in the penis, which interferes with that veno-occlusive mechanism, so where the vein constricts, not allowing the blood to flow back out of the penis once it's erect. A declining ability of the skin to sense vibrotactile stimulation, so they're less sensitive. Hypogonadism, which is a decrease in testosterone, which we know happens as a normal part of aging. And then the likelihood of chronic conditions that are linked to ED. So, for example, some of these ones that are listed above, like vascular problems, hypertension can cause some types of erectile dysfunctions. Medications can cause erectile dysfunction. Neurologic problems, or things that different types of diseases that might hinder the nerves, such as diabetes, that can damage nerve endings. Those things can also contribute. So how to prevent erectile dysfunction? From a prevention standpoint, we want to do a few things. We want to mitigate just general risk factors that put men at risk to develop erectile dysfunction. We want to mitigate risk factors that are very specific to particular patients. And then make sure that we have a good understanding of the medications that people are on. And potentially maybe use different types of medication to actually treat ED. So in terms of mitigating risk factors, different types of things can do this. So regular exercise, we know, help with lots of disease processes that we develop as we get older. Regular exercise, a balanced diet, healthy body weight, not drinking alcohol, and using tobacco. All of those things contribute to diseases such as diabetes, hypertension, different types of endocrine issues, which all can also contribute to ED. And then being very specific about mitigating those risk factors and individualizing that to your patient. So, for example, men with diabetes need to maintain appropriate blood glucose levels. Men with depression need to seek counseling. People with depression might often be on antidepressant medications, which are very big or widely known for causing erectile dysfunction issues. Many medications that we use to treat problems related to erectile dysfunction can themselves actually produce erectile dysfunction as a side effect. So we have to be very aware of what medications our patients are taking. Premature ejaculation is the next sexual dysfunction we're going to talk about in relationship to men. The definition of this is that a man consistently ejaculates before or shortly after penetration. So it happens very quickly. Healthcare providers are very hesitant to diagnose premature ejaculation unless these symptoms continue for greater than or equal to 6 months, and the gentleman reports that this is very stressful to him. The prevalence is pretty common as an isolated event, meaning that generally all men will experience this at least once or in isolation. Only 1 to 3% of men have a problem with premature ejaculation from a chronic standpoint, meaning that it happens over and over and over again. Some men experience this in all sexual situations, when others experience it only with certain partners or particular surroundings or particular types of activity. It's more common in the younger men, and in older men, it's more likely to be chronic. So in younger men, it's usually an occasional occurrence. In older men, it's usually a chronic issue. Different causes for premature ejaculation. It can be related to biological or psychological issues. There are a couple of different types of ways we categorize premature ejaculation, either primary or secondary. Primary premature ejaculation is often related to psychologic issues or events that occurred in childhood or during adolescence. Men with depression and anxiety orders might be affected more And then there can be some genetic and neurologic factors that contribute to primary premature ejaculation. Secondary premature ejaculation, on the other hand, is more likely to have a biological cause, and risk factors for people who might have secondary premature ejaculation include things like thyroid dysfunctions, prostate issues, urethral infections, opioid use, abnormal hormone levels or neurotransmitter imbalances, nerve damage, people with psychologic factors. And the fourth sexual dysfunction that we're going to talk about related to men is delayed ejaculation. The definition of this is extreme difficulty ejaculating despite the ability to maintain an erection for long periods of time. So these people are able to sustain an erection, but they are not able to achieve ejaculation. It is rare. It occurs mostly in gentlemen after the age of 50 years old. It's diagnosed when a man reports a marked delay in frequency or absence of ejaculation at all, or most partnered sexual encounters for greater than or equal to 6 months. It is distinct from retrograde ejaculation. So retrograde ejaculation means that ejaculation occurs, but the fluid travels to the bladder instead of outside. That is nearly always due to muscle and nerve damage from surgery or as a medication side effect. Causes for delayed ejaculation can include a primary delayed ejaculation, which is usually psychologic, or secondary delayed ejaculation, which is due to certain medications, various diseases or injuries, or procedures such as surgical procedures that have affected the nerve function in the pelvis. All right, so that covers the 4 types of male sexual dysfunctions. Again, those sexual dysfunctions include male hypoactive sexual desire disorder. So that has to do with the desire a man has to have sex. Erectile dysfunction, which is very common in men, and we're not quite sure how often this really occurs because some men will not report this for fear of embarrassment. It affects the arousal cycle of the sexual response cycle. And then we have premature ejaculation and delayed ejaculation. So let's move on to females. In females, there are 3 types of sexual dysfunction that we list in the DSM-5. There's female sexual interest arousal disorder, female orgasmic disorder, and then genitopelvic pain or penetration disorder. Collectively, about 12% of the women in the United States are affected with some type of sexual dysfunction. There are related problems not meeting the strict criteria for the DSM that cause concern to affected women and their partners, and including those problems that do not meet the diagnostic criteria in the DSM, plus the DSM-defined disorders. About 43% of all women report some type of sexual dysfunction. So let's talk about female sexual interest and arousal disorder. This is the most common sexual complaints that we hear about in women. It just includes a low or absent desire for sex, and women will have difficulties attaining an adequate level of arousal. So this affects the arousal cycle of that sexual response cycle. The diagnostic criteria include decreased or absent sexual thoughts, interest in sexual activity, mental or feelings of arousal and or pleasurable sensations during sexual activity greater than 75% of the time for greater than or equal to 6 months. So very similar to what we find in the male desire disorder. It causes a significant amount of distress as a result of this, and it has to be, again, like we talked about for the man, more than just a discrepancy in desire between that woman and her partner. The prevalence, it's the most common female sexual dysfunction, and all ages are affected, but it's most often reported in middle-aged women. Older women may be affected, but they're less troubled by it, or they're less likely to report it. We've also learned, though, that some women in older age, past menopause, will actually have an increase in sexual desire. So think about that as well. Make sure you're always individualizing your assessment to your patient. The pathophysiology for female sexual interest and arousal disorder is not very clear. There is a thought that it might involve a blend of physical and psychologic causes. As far as aging is concerned, there are normal physiologic changes in aging that could play a role. There are psychosocial effects that may limit people's desire for sex, and total or a near total lack of interest in sex is not usually very typical. Medical conditions can also cause problems. So endometriosis, cancer, uterine fibroids, pelvic inflammatory disease, a lot of times these issues will actually cause women to have pain during sex. There are side effects of medications that are used to treat other conditions that can actually affect your libido, just as medications can affect the libido in men or erectile dysfunction, cause erectile dysfunction. Psychologic factors can include things like depression, anxiety disorders, schizophrenia, PTSD. Women who are experiencing some of these may also have a decreased drive. Other factors to think about are women who may have been victims of sexual abuse. They may have had some type of childhood trauma. There have been some alterations in their body image, and they're having some body image issues. Body image can be very disturbing for women, and men too, if they have some type of negative connotation with their body image. That can be pretty directly linked to how they feel about their sexuality. And then cultural and religious attitudes towards sex can also affect this illness or disease, disorder. The next one we're going to talk about is female orgasmic disorder. The definition for this is a persistent delay or absence of orgasm following a normal sexual excitement. The diagnostic criteria for this are difficulties with orgasms greater than or equal to 75% of the time for greater than or equal to 6 months. It is significantly distressful for the woman and may be diagnosed when the woman persistently experiences orgasms of very low intensity. Second most common female sexual dysfunction that there happens to be. So the first one has to do with desire and arousal, and the second most common one we see is a female orgasmic disorder. Some estimates will say that it is as high as 40%, but most likely it is somewhere between 16 and 28%. Up to 10% of women have actually never experienced an orgasm. This can be a lifelong problem. It can be acquired. It can be very generalized or situational. So again, something that is very individualized to your patient. Different causes of female orgasmic order can include, but are not limited to, a lack of sexual experimentation, self-exploration, and or education. So there may be some women who just have not experimented sexually enough or explored themselves enough to know how to have an orgasm, and they may need education. Physical factors can contribute. Genetic influences might account for anywhere from 30 to 50% of a variability in a woman's ability to orgasm in terms of frequency, how often. It may involve disruptions in sympathetic or parasympathetic nerves. There can be diseases or health conditions. Sorry, y'all, I forgot to turn my phone off. There can be diseases or health conditions that might impair orgasmic function or make sexual activity very difficult or painful. So whenever we talked about things like endometriosis, different types of surgeries, those things can cause impairment. Certain gynecologic surgeries can cause physical or psychological changes that make orgasm very difficult. Alcohol and recreational drugs and medications, psychologic contributors, which are similar to those for other sexual dysfunctions. Relationship problems can cause female orgasmic disorder, and then again, cultural and religious influences. All of these sexual dysfunction disorders can are very similar in terms of the things that can cause them, and all of them can have either physical or psychological components, or in some people those things can be combined in terms of causing the issue at hand. Genitopelvic pain and penetration disorder is the last disorder we'll talk about for women in terms of sexual dysfunction. And this is just a persistent or reoccurring dyspareunia or fear of pain before or during vaginal penetration. So this is basically painful sex. It may involve vaginismus, which is an involuntary tightening of the pelvic muscles which prevent penetration from occurring. The diagnostic criteria for this include that the symptoms have to be present greater than or equal to 75% of the time for greater than or equal to 6 months, and that it has to cause significant distress to the person as a result. It may involve the entire vulva or only a portion. It may occur in all situations involving penetration, or its possibility excuse me, or it is a possibility that it may only occur in specific scenarios. Sexual intercourse, so for example, it might occur only during sexual intercourse, but not during a gynecologic exam. Or it might occur during gynecologic exam, but not during sexual intercourse. So that's what we mean by specific situations. Or it could occur in all situations. So the prevalence of genitopelvic pain and penetration disorder, around 14 to 34% of younger women will experience this, and about 6.5 to 45% of older women might be affected. Wow, that's a big range. 12 to 21% of women in North America will experience ongoing pain during sex. And then there's sort of a smaller percentage of that that category of women who experience vaginismus, which is that tightening of the muscles that will not allow penetration to occur. So it's usually an acquired condition, and there can be several causes for that. So there's inadequate lubrication. There might be some type of inflammation or abnormality of the vulva and the reproductive tract. There can be declines in estrogen or irritation that is caused by contraceptive foam, creams, sponges, or latex products. Women who experience deep dyspareunia, so a pain that is very deep inside of the pelvis during sex, is often linked to some type of pelvic disease or abnormality, such as like endometriosis would be an example of that. Primary vaginismus can be caused by malformations of the genital tract or a hypertonicity or poor control of the pelvic floor muscles. There can also be some psychologic causes that contribute to this disorder. It can be linked to sexual trauma or abuse, relationship difficulties, painful or traumatic childbirth, the presence of other sexual dysfunctions, high levels of anxiety or fear, and then fear and sexual pain often have a really cyclic relationship. So if that fear is there, then the woman will more than likely experience the pain. It may be a result of multiple physical and psychological causes, so there can be a combination of these that cause this disorder. Women who grew up in a very sexually repressive environment are at a much increased risk to experience this disorder. And the condition is more common in societies where women have very few sexual rights. They are subject to practices such as forced marriage, child marriage, and polygamy. All right, so let's talk about collaboration. For male sexual dysfunctions, the treatment starts with the least invasive method. So we don't jump straight to the most invasive method. We try the least invasive method first. So getting that man to change his lifestyle if we need to. We do a very thorough patient history and physical exam. We check for related health and medical problems. We do a medication assessment. We might need to follow up with diagnostic tests as part of the physical exam. So CBCs, urinalysis, lipid profiles, kidney and liver functions, testosterone, prolactin, the different types of hormones, PSA levels. And then for erectile dysfunction, we may have to do a diagnostic test, which is nocturnal penile tumescence and rigidity monitoring. So a lot of the times at night, men will have erections subconsciously or unconsciously, I guess I should say. And there is a test that we can do to monitor that. So those gentlemen experiencing or complaining of ED may be referred for that type of testing. As far as pharmacologic therapy is concerned, we can do different types of hormone replacement for low desire or erectile problems that are related to insufficient testosterone. We could do injections into the base of the penis. We can do transdermal patches. So the ones into injections into the penis would actually be a treatment for erectile dysfunction. There are also testosterone injections that you can give patients to increase their testosterone. And again, that can come through a transdermal patch, an injection, or a topical gel. Side effects of those hormones can be acne, weight gain. They can cause increased blood sugar, priapism, which is an erection that doesn't go away, renal stones, and jaundice. And then if we're specifically talking about erectile dysfunction, we can give medications orally through injection into the penis, or we can actually insert suppositories into the urethra. The most common oral medications that you're going to hear about are sildenafil citrate, which is commonly known as Viagra. There's a vardenafil hydrochloride, which is Levitra, tadalafil, which is Cialis, and vanilafil, which is Stendra. The injectable medications for erectile dysfunction are things like alprostadil, and this is difficult to administer, so it is not really the first one that we jump to. We would start out with oral medications, but if that patient can't use oral medications, we would put them on an injectable or the suppository, but those are not probably the ones that patients want to jump on right off the bat. It's really important with these medications that the patients do not take these with nitroglycerin and are very careful about taking these with blood pressure medications, specifically things like alpha adrenergic blockers. You can only take, with Viagra, you can only take this once a day, and the mechanisms of action really for these oral meds is that they help relax the smooth muscles of the penis so that there can be an increase in blood flow to cause the erection. There are not very many reliable medications that are specifically on the market for premature or delayed ejaculation. There has been some research that has shown that some types of antidepressants and topical anesthetics could be useful for these diagnoses. And then there are lots of non-pharmacologic therapies that we can utilize to help with male sexual dysfunctions. So surgery is one of those. It is very limited in its treatment of erectile dysfunction, and it is only reserved for cases in which all other interventions have failed. So remember we said the least invasive method first. When all of those have failed, then that gentleman might opt for surgery. We can do revascularization procedures, but those are generally unsuccessful and the results are often temporary. We can implant actual prosthetic devices, so we can put malleable rods into the corpora cavernosa. We can use inflatable implants that will fill with water through a pump. And then men are generally satisfied with prosthesis. They're, however, also at an increased risk for infection once they have these. Non-pharmacologic therapies again. Assistive devices. So we can use a vacuum constriction device specifically for erectile dysfunction. People will refer to these sometimes as a penis pump. For delayed ejaculation, there is something called penile vibratory stimulation that has proven to be successful. And for premature ejaculation, we can recommend condoms because that will reduce the genital sensation and hopefully prolong that man's ability to ejaculate. And then obviously counseling and other behavioral therapies as needed for your patient, particularly if we're talking about a psychological component contributing to these disorders. All right, so what about females? It's very important to have a really good patient history with males and females. We have to understand what the degree of the problem is. We need to know about lifestyle habits, different events that may have happened prior to the problem that's being reported, what types of medications the lady is on, what types of diseases or illnesses has she been diagnosed with, a physical examination and inspection of the external genitalia, and a very focused pelvic exam. For women with vaginismus and or dyspareunia, they might not tolerate a speculum or more than one finger during a pelvic exam. So if that's the problem that they are presenting with, you might have to be very careful about how you approach that pelvic exam. Laboratory tests can help confirm or rule out other conditions that could be contributing to the sexual dysfunction or the sexual problem being reported. So again, some of the same things as we talked about with men, CBCs, urinalysis. We can do a Pap test on women, also a Pap smear. So that would be part of the pelvic exam. Pretty standard. Kidney, liver, thyroid functioning tests, blood glucose. We can get, we can draw hormones, so estrogen, follicle stimulating hormone, luteinizing hormone. We know that when women hit menopause, that their follicle stimulating hormone is very high and their estrogen begins to decrease. And so if aging is a part of what might be causing this, we could potentially tell from drawing on those hormones. There are some pharmacologic therapies that can help women who report some sexual dysfunction. Hormone replacement therapy is the most common pharmacologic treatment. Patients who have a very low desire, low arousal, or sexual pain will often respond to this. Estrogen replacement is something that's pretty common. It increases the sensitivity in the genital area and causes lubrication to happen. It can also relieve dyspareunia in some cases. It must be administered with progesterone in women who have a uterus in order to reduce the risks for heart attack, stroke, breast cancer, dementia, thrombolytic episodes. So it's very important for women who have not had a hysterectomy, who are placed on hormone replacement therapy, to take estrogen with a progesterone supplement. And because of those risk factors. And we often do not like to use hormone replacement therapy for a really long period of time. We prefer to keep hormone replacement therapy to short-term use because of the risks. So, hormone replacement therapy can include things like selective estrogen receptor modifiers, or SERMs. These mimic the action of estrogen, but the benefits are that it gives a similar effect as the estrogen and progestin combinations, but it lowers the risk for, lowers the cancer risk of those. Testosterone is another one that we can give for women. This is not FDA approved for female use, but it is prescribed off-label to postmenopausal women, and the potential risks and side effects must preclude the use for many women. So we definitely need to be outweighing benefits and risks before prescribing testosterone. Bupropion is an antidepressant with desire increasing effects. So most antidepressants have the opposite effect. It will actually decrease desire, but this particular one has known to have some desire increasing effects. So that might be one we put women on. Flubanasir, I don't really know how to say that very well. Flibanserin, that does not even sound right. Anyway, that is the only FDA approved drug for the treatment of low desire in women. But it may be tricky to prescribe because it hasn't been really shown to be extremely effective. It can have some potentially dangerous interactions, and it costs a lot of money. So we might not see that one as often. There are also some non-pharmacologic therapies that we can do to help women who have sexual dysfunction disorders. There are different types of assistive devices. There are vibrators, clitoral vacuum devices, lubricants, vaginal moisturizers. There are also vaginal dilators for women who have genitopelvic pain or penetration disorders. And then obviously, if we're talking about psychological components that are contributing to these sexual dysfunction disorders, counseling and behavioral therapies would be very appropriate. All right, so let's talk about the lifespan. Pregnant and postpartum women, there are a lot of changes that come along from a physical and a psychological standpoint with pregnancy and childbirth. And some of these can cause sexual dysfunction in women that were not there before. For women who are pregnant, they often will report problems, usually during the third trimester. But sexual problems can vary from trimester to trimester, and it can also vary based on the experiences of your patient. So if you have a patient who has had many miscarriages, they may report low desire throughout their whole pregnancy. But in general, women find it a little more uncomfortable, particularly, and find more difficulties with sexual relations in the third trimester because of changes in body size, different mechanics involved. They also have decreased androgen levels in the third trimester, and they might be fearful that having sex can harm the baby. It is actually fairly safe to have sex in the third trimester unless there is some type of problem that the woman is experiencing to cause it to be unsafe. But in general, for a normal, healthy pregnancy, sex in the third trimester is perfectly fine, and we might want to just suggest some position changes to help with mechanic issues so that the mom's belly is out of the way. Sexual dysfunctions can worsen for women after childbirth. Again, we have decreased androgen and estrogen levels, and then our prolactin levels actually increase. And this all can combine can cause a reduction in their desire to have sex. It can also cause vaginal dryness, and which can lead to painful sex. Excuse me. Delivery-related damage to the vulva, the perineum, or the pelvic floor can also cause sexual sensitivity or sexual pain after childbirth. So those might be issues we need to discuss or assess related to women after childbirth who are reporting sexual dysfunction disorders. Fatigue and anxiety related to their parenting duties can contribute. 90% of women, though, will actually resume normal sexual intercourse by 3 months postpartum. There is little research on treatment, and again, it's worth mentioning that the nurse can suggest experimenting with positions and alternative activities, particularly for those pregnant women in their third trimester. All right, what about older adults? So sexual dysfunction tends to increase with age in both men and women. For women, it coincides with perimenopause and menopause, and for men, it coincides with male climacteric, which is that just gradual decrease of the functionability of our sexual hormones and our reproductive organs. Hormones are not solely responsible. It might be linked to different psychological and physical issues. So chronic disease, medications, role changes in life, grief, fear of death, or just plain old physical decline. Older adults are often very reluctant to discuss sexual dysfunctions with their healthcare providers. But it is important for the nurse to reassure patients that an interest in sex is normal even at an older age. The nursing process for these patients. So let's think about what the nursing process is going to look like with people who are reporting sexual dysfunction disorders. You might encounter these patients anywhere, in the hospital, in the community setting, in a doctor's office, at a health department, home health. You might encounter these people anywhere that you work, in the prison, anywhere. So you oftentimes will be the first member of the healthcare team to discover that the patient is having sexual difficulties, particularly because they tend to trust nurses more. We're with them more of the time, and they feel comfortable telling us things, or we prod them with lots of questions, and they respond. So you might be the first person to find out that this person is having an issue. So you play a really critical role in communicating that information to the correct people, the healthcare provider, providing emotional support for that patient, and then referring your patient to other care providers to help with their problem. From an assessment standpoint, we want to find out as much as possible about the problem. We want to complete a physical exam, do further diagnostic testing as appropriate and as ordered by the healthcare provider. Ask the patient about other factors that might contribute that are not apparent during the physical exam. So possible psychological things that could be contributing to their problem. And always remain very compassionate and non-judgmental, because this is a very difficult thing for patients to talk about. They are very embarrassed to talk about this oftentimes. Nursing diagnoses to think about whenever you encounter a patient who has some type of sexual dysfunction disorder are things like knowledge deficit, or knowledge deficient, ineffective sexuality pattern, a readiness for enhanced communication, readiness for enhanced relationships. Sexual dysfunction can actually be a nursing diagnosis within itself, and it's situational low self-esteem. So all of these would potentially be appropriate nursing diagnoses depending on your patient, their problem, what they're reporting, and what they're experiencing is contributed to. Goals may include that your patient will discuss concerns without embarrassment or anxiety, that they will be able to talk to you about their diagnosis with a general understanding regarding teaching about medications or other factors that contribute to their dysfunction. They will be able to verbalize treatment options and make an informed decision regarding those, and that they can communicate more effectively with their partner about each other's sexual preferences, desires, or limitations. As far as implementation is concerned in the nursing process, the nurse is responsible for uncovering a patient's areas of concern, acquiring details about the sexual dysfunction itself, communicating that information with the primary health care provider, and in some cases, providing an ongoing assessment and teaching. Nurses have to maintain a professional affect. The patient might find it very difficult to talk about their sexual performance, especially if the nurse is younger than the patient. Be aware that the patient may experience decreased self-esteem resulting from their from experiencing their condition. So utilizing measures that can help promote their self-esteem are really a critical part of the care that you can provide from a nursing standpoint. And then evaluation. Expected outcomes that you might include in terms of the nursing process can be things like that the patient verbalizes an understanding of their diagnosis and contributing factors that lend themselves to that diagnosis, that they make an informed decision about their treatment options, and that they verbalize that the problem is not related to or a reflection of his or her masculinity or femininity or self-worth. So here's where that self-esteem comes into play. And that the patient and the partner can communicate openly about that diagnosis in ways that they can adjust their relationship to address the problem. All right, so that is your lecture for individual module 4, the concept of sexuality, specifically regarding sexual dysfunctions. Thanks, y'all.